Hello, everybody. Welcome to Joint Ventures by Smith+Nephew Sport Medicine. I'm your host, Ian Lowe, and today we have two guests with us, Dr. Michael O'Brien, Tulane University, and Dr. Scott Trenhaile, Ortho Illinois. Thanks for joining me, guys. Today, I think we're going to talk a little bit about rotator cuff tears, how your practice has changed really over the last 10 years or so, and really about the REGENETEN Implant, how that has changed the outcomes for your patients. Now, Scott, I know you were involved with this implant really for a number of years. Tell me about your experience initially, before you had this implant. How were your rotator cuff patients doing?
I mean, we always think that our patients are doing fantastic until we really start to look at our results critically. And there was always a gap or a void in my treatment armamentarium where I just wanted to do better and thought I could do better with these patients. And I actually started my whole experience on the large to massive rotator cuff conundrum,
right,
not the partials side of things. And I explored every patch, so to speak, that was out there, trying to find something to do better for my patients and make the outcomes better. And it
injectables and
everything.
PRP.
Yes.
Yeah.
Yeah, I mean, there have been so many biologics out there that really haven't stood the test of time. And,
Yep.
you know, when they first come out, you're like, oh, this is going to be the next thing, best thing since sliced bread.
Mm-hmm.
Right.
But critical appraisal, I think the outcomes are very different.
Agreed.
Yeah. So I started on the massive cuff tear side.
And you started augmenting those with different types of implants?
Yeah, you know, I of course was augmenting everything that was in danger of re-tear. Radiographic re-tear is where it's at. And just the outcomes weren't predictable. And so that's when I gave REGENETEN. Actually, back then it was under a different name, but I gave it a try, and I was like, this is different.
Right.
That was my start.
So what's your early experience?
Very similar.
Yeah.
And so Buddy Savoie is my boss, and he was an early adopter of the implant and actually helped, I think, design the arthroscopic implementation tool with Jeff Abrams. And similar to Scott, where you have these large and massive tears, and when you really follow them critically, you realize more fail than we want or that we want to accept.
Right.
And we follow ours with ultrasound, so then you can see at that 3-4 month mark that it's failed, even if your patient's doing well. So then what do you do? So REGENETEN became available, and I started, like Scott, using it as an augment on top of large and massive tears. And I had tried other things too, different forms of biologics, you know, but wasn't getting good results with that. And when I first started using it, I was super skeptical. I didn't think it would work. But I had heard people like Rick Ryu and Jeff Abrams present their data, and Buddy Savoie, and see their MRI outcome studies and show that they were getting these tears to heal. So I started using it. And following them long term, we could see it like in their range of motion, in their strength. Following it on ultrasound, we could see the implant on top of the rotator cuff, and then between 3 and 4 months, you can see it kind of disappear. So you know it's integrating into the tendon.
Yes. So this is interesting. So you routinely follow your rotator cuff repairs on serial ultrasound, like with every follow-up visit?
4 weeks, 8 weeks, 12 weeks, and then their last visit, whenever that is.
So just tell me then, anecdotally, like what do you see on these ultrasound with that implant? You know, the interface, maybe the tendon thickness. What are you looking at? What do you see?
Yeah, all of those things. So, you know, if you get someone to put their hand on their hip, it brings the greater tuberosity forward from under the acromion. And so then you can see the greater tuberosity, and you can see where your anchors are, so you know exactly where your repair is.
Oh, interesting.
And early on, you can see a space between the implant and the tendon. And early on, it's about 2 millimeters. So you can measure the thickness of your tendon and then the thickness with the implant, which adds about 2 millimeters as the implant swells a little bit. And then I think it's around 4 months that the implant completely integrates. And then it's just looks like one tendon. Wow. And so we follow that over time.
Yes.
Initially, just to kind of show that they were healing and not re-tearing. And we also kind of use that to guide their therapy. So if their repair looks kind of thin, we might not start strengthening right away. If the repair's looking good, we might start strengthening a little sooner, like 10 weeks versus 12 weeks or 15 weeks. But that was one thing that really led me to believe in the utility of this implant.
So who do you feel like, Regeneten is probably not going to help this particular patient or
Yeah.
repair?
Certainly you've got patients who are arthritic,
Okay, yep.
more on their joint is just a little too far gone.
Like a cuff arthropathy patient.
Yeah, pre-cuff arthropathy patient with a really large tear,
Yes.
probably north of 70 to 75 years old. And I can't prove that, but my clinical suspicion with tendon healing in general and how you add all those factors together, there's only so much this can do, right? There's guardrails, and I think those are some of the big factors where you'd say this doesn't make sense.
Yeah, similar,
Yeah.
because my current algorithm now is I put it on every large and massive tear, even somebody young, because if they fall skiing and tear their whole cuff,
Right.
you need that to heal. So
Definitely.
even a young person without medical comorbidities, you need that to heal. Every revision case, I have now started using it on the partial thickness tears. That's where I'm not really sure what is the cutoff, So in my mind, if it's 50% or less partial tear, that I use REGENETEN for.
Yes.
If it's over 50% or 80%, then that's where I'm not sure if that is enough to get that to heal. So then I still add an anchor in those high-grade partial
High-grade.
thickness tears. So when I don't use it is the arthritic patient. Sometimes if the tendon quality, if you can get a repair, but the tendon quality is really, really poor, where you
Right.
almost realize in there, like maybe I should be doing something else than a rotator cuff repair right now. And I don't use it on 1 centimeter tears because I don't think it needs it. The healing rates are so high
Right.
with 1 centimeter tears.
Yep.
But, there's data that supports putting it on every single tendon.
Okay, so you have been using it for partial tears. Have you been using it for partial tears as well, Scott?
Yes.
So what's your experience been with partial thickness tears?
Well, first and foremost, when you look at how patients do with that over a takedown and repair,
Yes. Or a transcendent repair.
which I really don't do at all anymore.
Okay.
But when you look at those patients clinically, they are so much happier just out of the box. They're less narcotics, they drive sooner, they go back to work sooner, they do all these things in their life. They're out of the sling in a couple of weeks. They're just returning back to life much sooner than a takedown and repair. And so there's that patient, and then there's the patient that maybe it was a patient who was getting an acromioplasty, but their cuff really didn't look good. It looked
tendinopic.
very sick looking tendon. And that patient they seem to do clinically better early on with less pain, more motion, activity levels, all of that.
I love that indication because before this implant, we would see those where you're going in there and you're doing an acromioplasty. They're having rotator cuff pain. But then when you look at it arthroscopically, the tendon it's not torn, but it doesn't look healthy.
Right.
It's all kind of beat up and frayed, which now I think we recognize is just early rotator cuff disease.
Right.
And that's one indication that I think is great because I think it kind of halts the progression of that, And you're bringing in blood supply and you're adding collagen to the bursal surface and you're helping that sick tendon heal before it becomes a tear.
At least you feel like you're doing something biologic.
Totally.
You're doing a acromioplasty, that's like a mechanical thing almost, like decreasing the impingement. But I feel
You kind
like
of feel like you're not doing anything with just an
yeah.
acromioplasty.
Sometimes I feel not often, but you're doing a acromioplasty for that disease. I'm like, are they just really doing rehab again, or what are we really doing for this person? Yeah, I wondered about that myself. So, are you doing this in all types of partial tears, like bursal surface, in-substance tears, articular surface tears?
Intrasubstance, yes. I think it's a great indication for an intrasubstance tear, and I'll trephinate the tendon with a needle, and then I might take the gold awl and microfracture the tuberosity a little bit and then put REGENETEN on top. If it's articular-sided, less than 50%, I'm using REGENETEN and accelerated rehab protocol like Scott mentioned. If it's 50% bursal-sided, I usually use an anchor.
Okay,
But then I still might add REGENETEN if the remaining tendon quality looks really bad.
Right. So there is this concern, though, I think, with the rehab protocols and developing stiffness after the use of the REGENETEN implant, what's been your experience with stiffness and REGENETEN?
Yeah, I think the thing in my experience that you have to understand is this device really accelerates healing. And with healing, you can get accelerated inflammation, good inflammation. There's good and bad inflammation, of course.
I mean, all healing starts with inflammation.
Right. And so patients, you'll see patients that are doing fantastic, and in between 9 and 11 weeks, they start to get sore. They may lose a little bit of range of motion, and it's all about counseling those patients and kind of weathering the storm, because there's a lot of good inflammation going on. Sometimes it's too good.
And I think it's important for them to also understand the rehabilitation protocol, particularly for treatment of partial tears.
Yes.
Because, if they've had a traditional rotator cuff repair before, that patient might think that's the rehabilitation protocol that's appropriate. But you got to move them early, right?
Yeah, and I think the physical therapists as well. So when this first came out and we were using it for partial tears, on the physical therapy order, I would send a protocol, but then the therapist looks at it and says, wait, you just had a rotator cuff repair. You should be in a sling. You can't be raising your arm up yet. So I think educating the patients that it's okay to move your arm, because we didn't have to reattach anything. This implant is on the top. It's stable. It's not going anywhere. And then also educating the physical therapist that it's okay to push these patients a little harder and start strengthening at 6 weeks.
I totally agree with that, because I used to write just, like rotator cuff repair with graft. But, traditionally, if we would use like a different type of graft, it was super slow, super immobilized. And I was like, this is a huge mistake. I should have never wrote that.
And I think that's what they think when they see that.
Yeah.
And so they're thinking, oh, sling for 6 weeks, no strengthening till 12 weeks. And so sometimes I'll try and send the protocol with them.
Yes.
Say like sling for a week, out of the sling at 1 week, start using your arm, start active motion, start strengthening at week 6. And hopefully by educating patients and physical therapists, that'll help that.
It's interesting because when this came out and we got into all those kind of miscommunications about all this, we ended up developing small cuff protocol, large cuff protocol,
Same.
bioinductive implant protocol, subscap precautions, all of these layers, and everybody got smarter.
Right.
Everyone involved through the continuum of care. It got better.
So with that now, is stiffness a problem?
No, because we anticipate it, and we don't make the mistake of locking people up in a sling too long. I've got cases of people where I was really concerned early on with these large to massive tears. I put the device on, locked them up in a sling like I always do, and next thing I know, I got a stiff shoulder because I waited too long.
Right.
I think stiffness is really rare. And I think probably we all have seen a couple where using REGENETEN on the bursal surface for a partial tear where some stiffness develops. And I don't know if that's the inflammatory response. I don't know if it's the patient being extra cautious. But kind of like Scott said, for me, it's that 8 to 10 week time point where they're doing okay and then they start getting a little stiff. That's pretty rare.
It's pretty rare.
It's pretty rare. And I don't see it in using it as an augment for the large and massive tears. They don't get stiff, And that's a traditional rehab protocol where they're still in a sling for 6 weeks and start strengthening at week 12. They don't get stiff.
This is just kind of a sidebar, but I always try to point out to people, like, we have to make sure that we're treating rotator cuff disease and not treating impingement, which may also be early onset frozen shoulder, because those can present similarly. And is this a cuff problem or something else? And you don't want to get thrown into that category by mistake. And that's why we don't rush into surgery right away. We try to rehabilitate people and avoid surgery if we can.
Right? Yeah, absolutely. If you have somebody that is getting a little stiff and they have a REGENETEN implant in, will you put a cortisone injection in the subacromial space, and at what time frame?
That's an 11-week, yes. Yeah. And it's later.
Me too, 12 weeks.
Like a 3-monther, yeah.
Yeah, I'm usually 11 because by then they're in my office and they're worried, right?
Yeah.
So, but it's really rare.
Agreed.
But you have to remember too, even though there's this incidence of stiffness per se, if you were to do a traditional takedown and repair, I know, small parts. Those ones used to get stiff all the time.
They
too.
get
Way
more
worse.
stiff.
They're like
Way
those
worse.
are actually I find them my angriest patients.
Oh, angry. And it's
Yeah.
usually young males. You know, they're in their 40s. They're super stiff. They're unhappy because they still hurt.
Yes.
They can't raise their arm up. And I think it's just by doing a takedown and repair, you're shortening the tendon. So you're changing the natural length of that tendon than it was meant to be. And so it makes sense that would lead to stiffness. Yeah.
Yep.
And those are the ones you wanted to get back early. Like those are the young people. You're like, oh yeah, sorry, you still can't work now because that thing bloody hurts.
And they're so unhappy. And that's where Regeneten has been a game changer in those patients.
Right.
Because you can move them faster. And at 3 months, they're feeling pretty good. I've
They
had
are.
some folks, partial tear with Regeneten in 3 or 4 months being back to everything. Pickleball and tennis.
I remember this distinct patient, probably just about 6 months ago. We operated on him. Partial thickness tear, bursal surface. Maybe I broke protocol a little bit. It was probably 80 to 90% of the way through. I'm like, oh, that's a little dicey. Like, don't get me wrong. I trephinated the bone. I put the Regeneten on top just to kind of extend it out. This guy, I saw him at 3 months. He's like, oh, it's fantastic. Full range of motion. He's curling 40 pounds dumbbells either side and 80 pounds single hand overhead.
awesome.
I'm like,
Wow.
that is crazy.
I thought you
Like-
meant he was actually curling like the sport up in Canada, but dumbbell.
Well, I mean,
curls.
partly. I mean, he was curling like
Those
curling
as well.
stones.
Curling
Yeah,
bicep
those are
curls with curling
I mean, that's
stones.
the thing. And
I mean, that's a good outcome right there.
I was
that's
crazy.
the definition
He
of
was
a
like
good
an
outcome.
80-pound dumbbell press
Yeah.
overhead. I'm like, what? Like, there's normal people who can't do that. And this is not a big dude. I mean, he wasn't as big as Scott, obviously.
Few are.
Yeah, few are.
Here we
as
go.
you said, as you
Okay.
said. Okay. Okay, so when you're introducing this implant to patients, there's been some concern related to the source material, which of course, as we know, is bovine. And industry-wise, this term xenograft has been utilized for other implants. And so when you first saw this and it was, bovine source, what did you think?
I thought I wanted to know more, obviously. I wanted to know where it came from, how it was made, how it was processed, what's in it, what all the ins and outs. And, some of that information is proprietary, so we didn't know all of it. But I knew enough to know that this was basically a highly purified collagen graft or implant, rather, that was derived from an Achilles tendon of a cow. And the way I explained, so once I started to understand that, I basically just tell people exactly what it is. This is an Achilles tendon of a cow. It's broken down into its finite elements. It's actually broken down into a powder, made back into a slurry, and then it's like a wet potato chip when we put it in. And it's essentially a man-made product with very little to no DNA. I mean, it's hard to trace. Once I kind of walk people through that, they seem pretty okay with it because it's an engineered product.
Yeah.
I feel like I knew way less about it when I first started using it. I knew it came from a cow Achilles tendon, and that was it. And didn't know how it was bioengineered. And learning that, especially in the last 6 months, that the source DNA is removed as this is highly bioengineered and this is a pure collagen implant, helped me understand how it works a little bit better. And with the high porosity, that helps you understand how that can bring in blood flow and the tenocytes can start growing into the implant. I would first tell patients, when I first started using it, I had the brochure provided by Smith+Nephew, and I would show them a picture of it and say, this is a collagen implant that comes from a cow Achilles tendon. It's FDA approved for this purpose. It's the size of a postage stamp.
Yep.
We're going to fix your tendon, and then we're going to slide it in and insert it over the top, and it's should help the tendon heal, and it should integrate into the tendon within 6 months. I had 2 patients. When to not use it. One lady told me, I have a beef allergy.
Yeah.
And I was
Right.
like, what? I'm allergic to beef. So I called the engineers, and they said, I wouldn't use it. So we didn't.
Right.
And then I had a man who was a vegan. And so when I said, cow Achilles tendon, he said, I'm a vegan. And I said, that's great. And he goes, I don't want that in my body. And I was like, oh, okay.
Yeah.
So he chose not to go that route.
And there are, of course, certain religions where that may be looked down upon, but I've actually had people of that religion, some are acceptable to it, and some are not acceptable to it. So I just explain exactly where it's from, and how it's processed, and how it's made, and some of them are still agreeable to it.
Yeah.
Some of them are like, if you feel like this will make my outcome better, then I'm still okay.
I trust you.
Yeah.
And now, you guys have probably had a similar experience. Some people will come in asking for it. So they've heard from friends or acquaintances that they got this collagen implant, and so they'll come for a second opinion and say, can I get that implant? Because I've heard it helps with healing. So I've had some people come in asking for it.
Yeah. And in fact, I find that if I talk to the patient about the implant, but I don't put it in, they're so disappointed.
Oh, yes.
They're like, well, why did you put that in? Oh, what?
And you're like, well, I don't think it needed it. And you said it would make it better.
Yeah.
So I learned that the hard way too.
I mean,
hurt feelings, and then I felt like an idiot, and I'm already an idiot.
We're having trouble enrolling patients. We're always studying this, right? Yes. We're always doing research. And the patients don't want to be enrolled because they're fearful of being randomized to one arm over the other. They want the device.
Right. They want the
they
device.
Totally want the device.
And that's our problem, is that the population has become a lot more savvy to what this is and what it can do.
Okay, so if you have somebody who's thinking about maybe using the REGENETEN, what are your kind of tips and tricks for that first case? Who's the best patient to try it on? Maybe the easiest person to put it in? How would you approach that?
I think, and I guess it depends. If a user wants to start with a partial tear or an augment on a full thickness tear. But on a partial tear, I think my best tips are you don't want to put it over the rotator interval, because if that creates thickening of the rotator interval, that might lead to some stiffness. And so when I'm intra-articular, I drop a spinal needle down at the anterior aspect of supraspinatus, right behind the biceps, and I leave it there. So then when I go up subacromial, I see that spinal needle, and it's a runway of where to put the implant. And I have found, I do this in beach chair position, and so my lateral portal to bring in the implant is lower than my standard lateral portal because I'm trying to bring it in parallel with the rotator.
Land it like an airplane.
Land it like an airplane.
That's you got to come in flat.
Yep. And so I get that angle with a spinal needle. I put it in through a cannula. I bring it in. I make sure it stays posterior to that spinal needle, marking the rotator interval. And I like the peak bone staples. So I use 3 soft tissue staples, medial, 1 or 2 anterior, 2 posterior, and I usually use 1 peak bone staple. Scott, you don't use the bone staples.
No, I do about the same.
Okay.
You end up getting 1 bone staple at that corner where you run out of tendon, and yet it's all about coverage, right?
Right.
So it doesn't propagate beyond what you've covered. So you need to get the implant over the diseased tendon.
Right.
And if you've got a flap or an edge that's hanging over and it's on bone, then use the staple. It's okay.
Yeah.
But it's just purposeful that way, not because you're trying to bear load immediately with it, because we know that's not the point.
Yeah.
Right?
On revisions, I've brought it in both ways too, from bringing it in lateral, in line with the tendon fibers, or posterior, perpendicular to the tendon fibers, and it doesn't seem to matter. It doesn't seem to affect the healing rates of the implant. And so I think it's kind of dealer's choice.
By ultrasound, you mean?
Yep.
So why would you bring it in lateral? Or posterior, rather?
So in certain instances where if I'm able to get, it's a revision and I can only get a single row repair, and I don't want to bring it in over a big knot stack because it's not going to integrate over a big knot stack. So then I bring it in from posterior and I put it a little bit more medial and use all soft tissue staples.
Yep.
If I can get a good double row repair, then I bring it in from lateral, because I believe in covering that bone tendon junction as a possible source of failure.
The other thing I find is if you are bringing in it from lateral to medial, there's a tendency to push the graft.
Oh,
medial,
yes.
right?
Great tip.
So what are your tricks on that?
What I've seen is training residents and fellows, the first couple times they use it, they think they have to push really hard.
Yeah.
And so I'm holding the implant and I'm holding the scope, and they might push too hard medial, and then you see the whole thing shift medial.
Yep.
So I try and teach them ahead of time, get your starting point, bring your hand up, and then straight down. And you can really feel 2 pops. You can feel it pop through the implant, then pop through the tendon.
Yep.
And I tell them they don't have to push that hard. But I definitely made that mistake early on, where I pushed it more medial than I wanted it to be.
I find if I put the middle staples in as opposed to the medial staples in, it kind of stabilizes a little bit
that's
easier.
a good idea.
Where if you have the medial ones first, especially if they're slightly oblique, it tends to push it a little bit medial. So I try to stabilize it in the middle first, and then go medial, and then go lateral.
It's brilliant.
Well, and your angle is better.
It's more perpendicular.
Yeah.
It's more perpendicular.
Yeah. Makes sense.
Yeah.
That makes great sense.
Okay, so previously, we only really had anecdotal information to go off of as far as how your patients are doing. They seem to be doing better, but now we really have some level 1 clinical data. What do you think about those recent results, Mike?
I think it's outstanding. And so prospective level 1 randomized triple-blinded controlled trial, Ruiz-Iban out of Madrid, 120 patients, all 1 to 4 centimeter tears, so medium and large tears, randomized, all with a transosseous equivalent, randomized where half get REGENETEN and half don't, and to show a 1/3 re-tear rate at 12 months on MRI, and much lower type 2 CHO failure rate.
Right.
I think that's outstanding. And it's great because I think that validates what we've all been seeing and feeling and knowing that this has benefited our patients, and this study actually proves it in a much stronger way than the previous studies did, retrospective reviews, and even the studies that you and Bushnell did, which are good studies. But this one, it's the holy grail of orthopedic research.
It's liquid gold. That's what it is, because it just helps us get this device in our hands to help our patients.
Right. It really gives data. When you talk to patients now, you can talk to them about the trial. Actually, it's actually been proven in the literature now that this can help you, can help heal your tendon.
Right.
And it's really funny. If you talk to Ruiz-Iban, when he was first designing this trial, right? He was like, I don't believe in this technology. I'm going to prove that this technology doesn't work. So he said, what's the most robust thing I can do? Multi-standard, prospective, randomized, triple-blinded study. And now, with his results, he's a believer.
I love it. And I found that so compelling to find out that he set out on this study to prove that it didn't work. And then he believes his own data, of course, and now he is a believer and a big user. I find that so compelling,
And I do think that, some people will say, well, my re-tear rate's not that high. But I'm like, no, that's not what we're talking about. Because all of these patients were, in quotes, asymptomatic re-tears. Everybody got an MRI.
Yep.
And if you MRI'd every single patient in your clinic, you might be sorely disappointed what your true healing rate is.
100%. That's what I say to everyone too. That my patients do fine.
We as
I don't get
clinicians
re-tears.
have actually lived through that, right?
Yeah.
Right.
I have. I know you have.
Yes.
We've done research on how things were going. That was actually a segue for trying the REGENETEN. Back in the day, was we started MRIing people, and I was like, they're telling me they're doing great early on, and they get the MRI back, and you're like, oh boy, this is not.
Re-tear rates much higher than we thought.
Yeah.
Yeah,
and they get worse. They get worse as they, 5 years, 7 years, 10 years.
Midterms.
Yeah.
That's when everything starts falling apart.
Yeah.
Yep.
I think that's what's so great about the Ruiz-Iban study, because early on they're doing great, but now we know that long term they're going to do great, because we know all outcome studies show that a healed cuff performs much better long term than a retorn cuff, even if they feel better initially.
For joint preservation and everything. It just opens up. It protects the joint to continue to do what it's supposed to do, rather than just progression of disease and reverse shoulder later.
Yeah. Reversing reversomania.
Yeah. So. There you go.
And it's a funny thing, I used to think about this implant like, I don't want to do it in my older patients and that type of idea, because presumably they have a compromised healing environment. But I'm kind of like a little bit reversed now. Like in the younger patient with a medium-sized tear, we still know there's a known failure rate. And if that patient re-tears in that young population, it's like a disaster. Because I truly believe you got one chance to heal this thing. The first chance is your best chance.
Absolutely.
And so I'm like, I know you're young, but I think you should just have this.
Oh, absolutely. I agree. Like, I had a guy that fell skiing and he had a 4 centimeter full tear of superinfra. He was 48.
Yeah.
And I put a REGENETEN on because I agree with you. This is our best shot to get this right and get this guy to heal.
Especially with that size tear.
Yeah.
That's the bad actor.
Yep.
Right? That's the one that statistically could very well have a bad outcome.
Totally. Because then when those do re-tear, the tear is huge.
Yeah.
And your remnant tendon looks like garbage.
And you might be thinking about a different operation now.
Big time.
It's like,
Transfer or tendon transfer.
It's like, disaster time for this person.
Exactly. Dermal allograft, which hates me as much as I hate it.
I could get on board with that.
Okay, very good, guys. Well, Michael, thank you for joining me today. Scott, thank you for joining me today.
Thanks, Ian.
Certainly.
I think this has been a very interesting discussion about REGENETEN and how it's really changed your practice related to rotator cuff tears.
How it's changed our patients' lives. I think we're really making our patients better.
I agree.
But there's actually even more information coming out. Another prospective randomized level 1 study showing REGENETEN improving patients' outcomes again. But thanks for joining me today on Joint Ventures by Smith+Nephew Sport Medicine.